Okay, so we've set up the groundwork for continuing this discussion on how AI and ML can help with modeling diseases that are infectious, can grow into epidemics, and now we take the next step of looking at prediction and forecasting. So this group comes from the health side, so I don't know, we'll see how they're distinguishing prediction from forecasting. In our business also there are words predictions and forecasting used separately, differently. So let's just stick to what's here. During an infectious disease epidemic, policy decisions regarding the deployment and timing of interventions rely on reliable estimates of the number of current cases and forecasts of future cases. Which is always critical. Surveillance is one thing, but you want to be able to mitigate, prepare for, and recover from epidemics, which requires forecasting. For a given disease, the number of cases, hospitalizations, deaths reported by the public health surveillance systems over time are analyzed to inform key policy decisions. Although epidemiological datasets may include a rich variety of demographics such as ethnicity and age, clinical, geospatial and pathogen genomic information. Every time I start speaking, suddenly I start having a frog in my throat. So this information at their simplest consists solely of quantitative trends and can therefore be analyzed using a range of approaches, including statistical time series techniques, modern ML methods, and advanced deep learning models, including newer foundation models that we will look at in a minute in terms of a table. I've been involved in some early warning systems where you take something like cholera, Vibrio cholerae, and that tends to be related to zooplankton, which is related to chlorophyll. So you can use chlorophyll data, do empirical relations between chlorophyll concentrations and cholera disease burden, and try to make a link that way. So this is talking about a few more details on how to use AIML to make those better. However, surveillance data cannot tell us directly how many individuals are infectious at any given day or what the expected future trajectory of cases might be. Epidemic surveillance data are almost always noisy and affected by biases in reporting, for example, time variable delays, testing, for example, targeting of limited capacity or willingness to test in certain groups, and sampling, for example, towards groups that can more readily access healthcare. So those that make claims or come to hospitals will be tagged and recorded, whereas those that stay at home may be missed. For example, data may appear to suggest a declining epidemic, but this trend could be an artifact of time-dependent changes in reporting or declining testing availability. These data issues could lead to ineffective and delayed responses. Okay, so here is the table as promised. New AI approaches to answering key questions in infectious disease epidemiology, their potential effects, and the level of maturity in the scientific and public health community. I'm not going to read all the details, but basically we are looking at problem domain, method, potential effects, and level of maturity in terms of the details of epidemiology effects, level of maturity in scientific and public health communities. So process understanding may exist, but the scientific and public health community may not have translated into action items yet, for example. So let's read the top one. Inference of epidemiological parameters. So generative Bayesian and surrogate models are used for the methods section here. Potential effects. Incremental improvements in the speed and accuracy inferring epidemiological estimates, especially when data are missing. Faster generation and iteration of model results for policy. That's the potential effect. Level of maturity. Bayesian methods can be implemented easily in available software packages. Surrogate models need to be developed for specific applications. Okay, so you have similar things for epidemic forecasting and nowcasting, which is becoming more and more so after the pandemic of COVID. Several groups were running and posting the outcomes every day. Did they come true? Well, this is a serious question. Scenario modeling, so it's compartmental mechanistic models and RL agent-based models that are used here. Understanding mechanisms of disease spread, so graph neural networks, etc. Infectious disease surveillance, that's active learning and Bayesian optimization. Risk prediction, so that can be helped with multimodal AI. Analyzing pathogen genomes, protein language models, public health decision making, Markov decision processes, and RL, recursive learning, right? Let's make sure. I always do this. I read it, I remember it, and then instead of noting it down, I think, I'll remember it, and then I forget it. So let's go here, open the PDF. You shouldn't be doing this in real time, but hey, I'm doing this just as I find time. So unfortunately, I am not always as careful as I should be, but considering we are doing this for fun and for information purposes, we'll tolerate some not so efficient behaviors from me, right? It's not. RL as a string appears in so many places that this is going to be impossible. La 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 la. Purum purum. Reinforcement learning. There we go. I was almost right, but reinforcement learning. You know what that means, right? So sorry about that. So reinforcement learning, Markov decision processes, and reinforcement learning. What are the potential effects? Improved ability to learn optimal decisions from human-machine interactions, and level of maturity is still conceptual and theoretical. So this is what I mean by process understanding versus public health decision making. Okay, what are the important epidemiological concepts? Let's not read all of this. Fatality ratio, obviously, is the proportion of those affected by a disease who do not survive. It's done for different subpopulations. Forecasting, we know what that means. The prediction of a disease future trajectory using mathematical and or statistical tools. So they are saying forecasting is prediction, so they are not distinguishing. Even though the header here said predictions and forecasting for whatever reason. Generation interval, the duration between the infection of an individual and the infection of one of its secondary infections. So let's not go into that because that length of time varies among infector and infectee pairs and is therefore represented by a probability distribution. Infection networks, the spread of a contagion through a population represented as a weighted directed network between infectors and infectee. Nowcasting is basically for the very immediate period, a reconstruction of the current state of the epidemic as accurately as possible when contemporaneous data may be affected by reporting delays. Okay, in weather forecasting, typically nowcasting means what is happening literally now outside the window, and these can be useful for flooding and other events, could be cyclone and so on. And prediction is usually hours to days to seasons. There is no clear distinction between time scales of nowcast versus prediction, so you just get used to it. Reproduction numbers, they are average number of secondary cases arising from a single case in a population, also known as the R value in the SIR and SIER models. Transmissibility, the propensity of a pathogen to be transmitted between individuals, which is a combination of pathogen-related factors relating to the pathogen itself, for example, size of the inoculum and all the pathogen's ability to evade host immune responses, and host-related factors such as number and intensity of contacts a host makes. Quarantining, etc., are basically efforts to reduce R, right? Vaccine effectiveness is a measure of how well vaccination protects against infection, transmission, and/or symptomatic and severe disease, typically measured as 1 minus the relative risk of the outcome in vaccinated versus unvaccinated persons. When measured in a randomized trial, the term vaccine efficacy is often used. Tricky, but these are important formal terms we need to carry. Modeling mechanisms of disease spread. I'm again going to take very small pieces of text from the long paper just based on my own judgment of what are the most salient points. Infectious disease modeling has relied traditionally on mechanistic models that represent the disease transmission process as a simplified but definable process. Examples include mathematical susceptible, infected, recovered SIR equations, and individual agent-based models in which a simulation of transmission is constructed and each agent is assigned specific attributes and events. When fitted correctly to rich data, individual-based models generate insights into the transmission process and can be used to evaluate interventions. However, parameter inference is much harder to perform using agent-based models than for standard statistical techniques owing to their lack of analytical component. So that's where AI approaches are providing new ways to facilitate efficient inference through a range of innovative approximations that use deep neural networks, for example, by taking advantage of variational Bayesian inference. New neural network architectures can accommodate large and dynamical agent-based models. So basically, AI is agnostic to the physics, right? So you have first principles, governing equations, etc., that you want to follow, but the way AI works, you just give it a bunch of data and it can figure out what's happening without knowing what the physics or the governing equations are, and that's where agent-based models versus AIR can be very starkly different, and AI can add huge advantages in terms of speed and dealing with data, gaps in data, and so on and so forth. Very brief, but there are more details in the paper. Immunological and genomic interactions. Disease preparedness and response requires the timely detection of emerging zoonotic pathogens or new variants of known pathogens. Even though genomic surveillance is essential for monitoring the circulating genetic diversity, determining the epidemiological and disease phenotype of the pathogens identified usually requires time and resource-consuming experimental work. Advances in AI models change this paradigm by using genetic sequences as their input, capturing information about the pathogen proteins. So you can just jump the many lab steps and data gathering efforts and so on. These can pave the way for high throughput prediction of protein structures and pathogen phenotypes from genomic data, enabling rapid preliminary assessment of new phenotypes and ultimately reducing the amount of experimental work needed to obtain good predictive performance. We looked at it before in figure 1C, so this is what we were doing here. Genome sequences of newly discovered pathogens versus pathogens and or variants. So genome samples, structurally informed deep learning model, leveraging protein structure prediction tools, for example, AlphaFold, ESMFold, well, technical terms, but here is training data, viral genomic disease data sets, genome sequencing, so you do some interactions here to come up with high viral fitness and antibody binding disrupted, mutation in accessible to antibody coming in here, predicted trajectory, viral fitness. So low viral fitness and antibody binding not disrupted. So in terms of actions, this can accelerate the development of effective vaccines, enable variant-specific targeted interventions. So you know how we are advancing these time scales and accuracies as well. So you get the idea. So should we read more here? AI models applied to genomic data can also be used to classify virus lineages, infer when, where, and how a pathogen emerged, predict the pathogen traits such as transmissibility, escapability, and spread, and predict host specificity to identify probable cross-species spillovers. AI models can also enhance the accuracy of phylogenetic inference and enabling a more precise characterization of the infection processes. Obviously, many details there, technical details, but some terms probably you are familiar with. Phenotype, basically, as the virus keeps spreading, it doesn't necessarily have a new genetic structure, new genome. It just responds to environment, host, geographical location, etc., by let's say mutating and producing a new phenotype. Okay, it's basically trying to survive. It's not necessarily trying to make you sick, but your body thinks it's a foreign agent and wants to try to get rid of it by fighting ghosts, and then your body may overreact and then kill you in this process, right? So this is about classification of data types to investigate infectious diseases. So here is the coverage and here is accessibility. Data types include epidemiological, social and behavioral, biological, and environmental. Okay, so you can see accessibility, real-time individual level health data. Coverage is not high, but accessibility is also low. So primary care data, secondary and tertiary care data, app-based health data, and you move higher on accessibility but remain low on coverage for antibody immunity, antibody/immunity, human genomic data. There are lots of issues here. You cannot simply keep sharing human genomic data because of various concerns. So there is also metatranscriptomic data here, pathogen genomic data, metagenomic data. So accessibility increases but coverage remains low, sampling issues. Routine surveillance, social media and online research, crowdsourcing is becoming more and more common, so that's doing well in terms of accessibility. Human mobility data coverage goes up, but accessibility still remains low, just surveillance, monitoring, and privacy issues as well. General wastewater data, prevalence surveys, international flight data, accessibility coverage is high, but accessibility can be low. Earth observation, census data, weather and climate data, and so on and so forth. Okay, so AI-aided integration of key data, then data science and representative sampling. Despite a step change since COVID-19 pandemic in the ability to perform large-scale interdisciplinary data collection during disease outbreaks, data scarcity and geographical biases remain major obstacles in global epidemiological research. So this is what we are talking about here. These have been shown to exacerbate racial biases and lead to non-optimal public health policy decisions. Who gets coverage, who gets monitored, who gets help, healthcare, safety, etc. depends on, unfortunately, on things like caste, color, race, etc. And these obviously can affect everybody's vulnerability because nobody is immune when you have a highly contagious disease going around. In particular, the uneven and inequitable distribution among locations of diagnostic testing resources, including genotyping, results in biased sampling, limiting the representativeness and use of the data collected. It's not only the volume of data that necessarily provides the most insights, but also the quality of them. For example, sampling design and representativeness. This big data paradox has important implications for our ability to infer key epidemiological parameters, to make accurate forecasts, and to respond to emerging threats. Okay, so let's also look at how we would integrate the data sources once we do have whatever we have available. I have to look at the message because I have a meeting coming up. Excuse me for a second. Okay. A plethora of new data sources and digital tools is creating new approaches to the modeling of infectious disease epidemics. During the COVID-19 pandemic in the UK, the National Health Service COVID-19 app was downloaded. More than 21 million mobile phone downloaded to more than 21 million mobile phone devices, providing users with timely notification of infectious disease exposures and instructions in case of their contact with diagnosed uh, in case their contact was diagnosed positive. So you are doing things that have to be done carefully. For example, Google can track search data to be able to say if flu is spreading in a particular area, and they do better than the agent-based models and so on. So that's the same idea here. Use app-based data to crowdsource information. Such mobile applications are a major new source of individual level behavioral data for understanding and informing public health interventions. Research has shown how digital contact tracing apps could transform our ability to reduce transmission at a fraction of the cost of manual contact tracing, especially when pathogens transmit rapidly and only a minority of infected individuals show early symptoms, because then you may hit a big R replication rate very quickly. Okay, reproduction rate. Furthermore, contact tracing apps could provide new real-time data about the variation in transmissibility as a function of proximity and duration of contact, and how this variation changes through time and among pathogen variants. So you imagine you are going to the market and some app is telling everybody you are infected. Would you like that? Well, for the bigger cause you should, but people may get nervous and not use the app or turn off the app contact location service and so on and so forth. So there are many issues to be dealt with. As the global climate changes, the distribution and incidence of climate-sensitive infectious diseases such as dengue and cholera are expanding, and the analysis of these dynamics could be enhanced by AI. Collection and incorporation of past, current, and likely future climate data into epidemiological models can improve our understanding of key epidemic dynamics and the reliability of predicted short and long-term epidemic trajectories. Other opportunities arise when AI is used to improve short and medium-term weather forecasts. Recent research has demonstrated the potential for better climate modeling using physics-based models that incorporate aspects of AI. This will improve the evaluation of the effect of climate on infectious diseases, which results from changes in host and vector species distributions or from changes in human behavior and contact patterns. Okay, so obviously lots of useful things coming out. AI-driven disease modeling for policy. I'm going to be again brief on these things. During international health crises, such as the emergence of a novel pathogen infectious disease, countries face complex decision-making challenges across sectors, for example, health, economics, education, and social well-being. For example, if tourism gets hit heavily as it did in Sri Lanka, leading to its bankruptcy, COVID did that, do you want to tell the whole world what's happening? So they have to make very quick and serious policy decisions on how to portray the situation to outsiders. So this will help contain and mitigate disease spread, of course. International travel and urbanization mean that today's epidemics occur in tightly connected populations and can lead to pandemics within weeks of their emergence. So epidemic is still kind of local, regional. Pandemic is when it's just gone bonkers in large scale. Decision makers must assess the cost and benefits of policies that are implemented to protect public health by maximizing their efficacy while minimizing the negative and unintended consequences like loss of lives and livelihoods, all under great uncertainty. AI approaches that focus on developing generalized systems can potentially provide decision support. Consequently, the mechanics of how public health policy decision making is done and how data and model results are interpreted may fundamentally change with adoption of advanced AI. Let's read one more piece here, jumping ahead. Public health communication. AI can help that as well. Misinformation online and disinformation campaigns that deceive and mislead audiences can threaten the implementation and success of public health strategies against epidemics. Same for climate change action. The WHO highlighted the importance of fighting misinformation during the COVID pandemic and has outlined plans for reporting online misinformation. AI could be used here to identify and address misinformation and to empower effective public health communication. Owing to the variety, volume, and speed of modern online communications, spanning text, images, audio, and video, with fake videos as well, it's impractical to use traditional statistical approaches to investigate the dynamics of digital data. Instead, AI tools will support the analysis and synthesis of accurate and reliable information about health from the digital domain. Okay, so this is approach to public health decision making. So you have many steps here. Yeah, we are getting to the close, so maybe I should come back and do this separately, because otherwise I'll end up rushing it. So let's do this figure carefully and then wrap up the series in the next podcast. Okay, this is already 26 minutes, so I should stop anyways. All right, see you in the next part of this series.